This program is brought to you by Emory University.
Good morning, everybody. Our presenter this morning is Dr. Arielle Schwartz. For those that don't know, Dr. Schwartz, she is a first-year fellow in our clinical track. Did her undergraduate studies here at Emory. She's a Rochester, New York native. Did her undergraduate studies here at Emory, medical school at Georgetown, back here for residency. And I'm not going to give away the case. She's going to talk about a patient, as you can see, with new onset cardiomyopathy. So Dr. Schwartz, take it away.
Thank you, Dr. Williams. Hi, everyone. I'm Arielle, one of the first-year clinical fellows. Today, I'm going to be presenting a patient case and then discussing the diagnosis in some more detail. Can everyone hear me okay?
Yes.
Okay. I have no disclosures. So this is a case of a 69-year-old gentleman who presents to his cardiology clinic with 1 week of fatigue, chest tightness, and shortness of breath. He has a history of CABG in 2006 following an anterior wall MI. He also has hyperlipidemia and obstructive sleep apnea. Of note, since his last cardiology clinic visit, he had COVID several months earlier and experienced symptoms of fever, diarrhea, and fatigue, but had recovered completely. About a week ago, he noticed that he had some high heart rates at home, so he went to an outside hospital emergency room. There, he had a CT-PE protocol, which was negative for pulmonary embolism, but revealed interstitial edema and mediastinal lymphadenopathy. He brings the CT report with him today. In clinic, his vital signs are significant for a heart rate of 102. His blood pressure is 104/72. He's saturating 99% on room air. In general, he appears fatigued, but not in any acute distress. He has no significant JVD. His lungs are clear and he's breathing normally. And there's a normal first and second heart sound. He's tachycardic with some ectopy, but no murmurs or rubs are noted. His abdomen is soft and non-tender, and his lower extremities are warm without edema. An EKG is obtained in clinic. It shows sinus rhythm with tachycardia. His heart rate's about 102. He has first-degree AV block with a PR interval of 250 milliseconds, and he has T-wave inversions in the anterolateral, lateral, and inferior leads. This is his most recent EKG in the system from 2014. As you can see here, there are no significant T-wave inversions. The PR interval is still mildly long at 205 milliseconds, but overall a much more normal EKG in the past. An echocardiogram in office demonstrates a moderately dilated left ventricle. The LV looks globally hypokinetic, and the EF is about 15 to 20%. There's no significant regional wall motion abnormalities and no significant valvular pathology. Of note, his prior echo just 2 years earlier had an EF of about 45%. Given his new cardiomyopathy and significant symptoms, he was admitted to Hearst with concern for progressive coronary disease. His admission labs were quite unremarkable, as you can see. His creatinine was within normal limits and at his baseline. His troponin was 0.04, and notably, his BNP was elevated at 1,056. He had an inpatient angiogram. Unfortunately, I was unable to obtain the images, but it shows the known 100% proximal LAD stenosis with patent grafts, a normal RCA, normal left main, normal left circumflex. His LVEDP was elevated at 22 millimeters of mercury. Given his soft blood pressures, he was discharged with small doses of guideline-directed medical therapy, including carvedilol 3.125 BID, lisinopril 2.5, and he was started on Lasix at 20 milligrams daily. Given this new cardiomyopathy without evidence of progressive coronary disease, he was referred for cardiac MRI for concern of a post-COVID myocarditis or an infiltrative process contributing to his cardiomyopathy. Here we have three different views of the mediastinum by CMR. On the left, we have an axial view, which shows the bulky hilar lymphadenopathy, which was also mentioned on his outside CT report. From the coronal and sagittal views here, we can see areas of hyperintensity within the myocardium. These are areas of late gadolinium enhancement, which can be seen in the basal to mid-inferior walls, and also includes the infraseptal and infralateral segments as well. Additionally, in the basal to mid, or in the basal to mid septal wall here, there is mid-myocardial delayed enhancement as well, and some enhancement in the RV wall demonstrated here. Based on this patchy pattern of late gadolinium enhancement, which does not follow any one vascular distribution, the differential supports a more likely infiltrative cardiomyopathy versus a myocarditis. For those of you who I may have lost, just to summarize so far, this is a 69-year-old gentleman. He has a history of an anterior MI status post-CABG about 15 years ago. He presents with 1 week of debilitating fatigue, dyspnea, and chest tightness. An EKG in clinic reveals new prolonged PR interval with diffuse T-wave abnormalities, which were not present on his prior EKG. His echo is now demonstrating a new dilated, globally hypokinetic LV with an EF of 15% from 45% just 2 years earlier. His MRI is showing mediastinal lymphadenopathy and patchy late gadolinium enhancement in the myocardium, most clearly in the basal to mid-inferior wall. So what are our next steps? What should we do to further work up this cardiomyopathy? Because of the bulky lymphadenopathy, in addition to his LGE in the myocardium, there was concern for cardiac sarcoidosis. He was referred for whole body FDG PET, as well as a fasting FDG cardiac PET to evaluate for active inflammation. Here is an image from the whole body PET. The middle image here is a CT scan, whereas the two sandwiching images are FDG PET scans in different color scales. As you can see, there's very pronounced FDG uptake, most notable in this one lymph node here, which measures 2.7 by 1.5 centimeters. This type of pattern on PET scan is suggestive of either a lymphoproliferative disorder, such as lymphoma, or an inflammatory disorder, such as sarcoidosis. Here are images from the fasting cardiac PET, which also involves resting rubidium perfusion scans. So the perfusion scans are here on the bottom, and the fasting FDG PET scans are here on the top. From the rubidium scans, we are able to see this perfusion defect here, which corresponds well with the area of LGE from the CMR. On the top row, we see this area of hyperintensity here, demonstrating inflammation in the same area that has this perfusion defect. This is also demonstrated on the Sintermed processing scans. Again, the top row is the rubidium perfusion scans, where we see this perfusion defect down here. And then the second row is the FDG PET scans, where we can see this active inflammation in this same area. This is also nicely demonstrated in the polar map here. So based on his bulky lymphadenopathy and his metabolically active patchy cardiomyopathy, cardiac sarcoidosis is high on our differential. Can we make the diagnosis now? Can we start treating? What are our next steps? An actual tissue sample would be nice to confirm the pathology, and an endomyocardial biopsy was considered. But given the relatively low sensitivity of endomyocardial biopsies for sarcoid and the high complication rates, the care teams opted for biopsy of the mediastinal lymph nodes. The pathology here revealed non-caseating, also known as non-necrotizing granulomas. Unfortunately, I don't have the patient sample, but a representative case from the literature is shown here. The sample was also sent for AFB and gram stain, which were negative, and cytology and pathology were negative for malignancy. At this point, the diagnosis of cardiac sarcoid is made, and this is based off the presence of the extracardiac histology with non-caseating granulomas, plus evidence of clinical features consistent with the diagnosis of cardiac sarcoid, including new conduction abnormalities and patchy metabolically active infiltrative cardiomyopathy seen on our imaging studies. So what are our next steps at this point? Do we start immunosuppressives in the cardiology fellows clinic? What doses of immunosuppressives should we even start? Or should we just refer him to rheumatology for management? The patient was actually next seen in the Pulm clinic, where he was started on high-dose steroids at prednisone 60 milligrams daily. He took the steroids for 2 weeks, and his fatigue and cardiopulmonary symptoms improved. He was feeling great. Unfortunately, several days later, he developed mania and hallucinations from the steroids, and the steroids were tapered down. Rheumatology was consulted at that point, since his debilitating fatigue returned, and he was started on Imuran 50 milligrams daily and a lower dose prednisone at 20 milligrams daily. After 3 months of immunosuppressives and guideline-directed medical therapy is tolerated, his EF improved to 30% from the initial 15 to 20%. He was referred for ICD given his low EF for primary prevention. Several months following ICD implantation, he again felt worse and was describing fatigue associated with palpitations. An ICD interrogation revealed he was having frequent PVCs with 814 PVCs per hour. He saw Dr. Westerman in clinic and underwent a PVC ablation, which was localized to one of the papillary muscles. Following the procedure, he felt great, and his device was now reporting less than 1% of PVC burden. The most recent clinic note was in August, and he's doing well. He remains on the Imuran and the prednisone. However, the prednisone has been weaned. When the prednisone was weaned to 2.5 milligrams, his PVCs returned. So his prednisone is now at 4 milligrams daily, and he's feeling well. His most recent EF is 35%, and he remains on guideline-directed medical therapy on metoprolol 12.5 milligrams and lisinopril 5 milligrams. To summarize the case, cardiac sarcoidosis can lead to heart failure, conduction abnormalities, and/or arrhythmia, as seen in our patient's case. It is a very challenging diagnosis to make and requires a high index of clinical suspicion. The hyperenhancement in the CMR, as well as FDG uptake on PET in an area not otherwise explained by coronary stenoses or ischemia, is suggestive of cardiac sarcoidosis. The patient's symptoms and EF improved with immunosuppressants. For the remainder of the talk, I'd like to discuss sarcoidosis in general, focusing mostly on cardiac sarcoidosis. We'll talk about the clinical manifestations, the diagnosis, and some of the diagnostic challenges. We'll review treatment, discuss indication for devices, and touch on future directions. Sarcoidosis is a disease that dates back to 1899, when a Norwegian dermatologist, Dr. Hutchinson, coined the term to describe skin nodules. Given the lesions resembled sarcoma, he called the condition multiple benign sarcoid of the skin. Since that time, sarcoid has been identified in many other organ systems, as demonstrated in this image. How do patients present? Majority of patients present with nonspecific complaints such as fatigue, weight loss, and fever. In 20 to 50% of patients with acute presentations, The constellation of erythema nodosum, or these red bumps on the anterior shins, bilateral hilar adenopathy as seen in this chest x-ray, and polyarthralgias are observed. This is known as Lofgren syndrome, which is a syndrome I've been tested on many times, but I've actually never seen in practice. Who does sarcoid affect? It is most prevalent in Scandinavian countries and in African Americans in the Southeast US. Adjusted annual incidence among Black Americans is 3 times that among white Americans. The average age of onset is 40 to 55 years of age, with a younger peak age at diagnosis in men between 30 to 50 years compared to women, which is 50 to 60 years. Having a family member with sarcoid is associated with a 2 to 4-fold increased risk of developing sarcoid. Moldy environments, occupational exposures to insecticides, and agricultural employment all are associated with the disease. Interestingly, rescue workers from the World Trade Center disaster from 9/11 have been shown to develop a sarcoid-like pulmonary disease. More recently, case reports have been published documenting pulmonary sarcoid following COVID pneumonia, which is interesting given our patient had COVID-19 just 4 months prior to his presentation in clinic. So what causes sarcoid? Despite the efforts of several generations of researchers, our understanding of the disease mechanisms and general epidemiology remain limited. Epidemiology studies suggest findings consistent with transmission and/or environmental triggers. It seems most likely that genetically predisposed hosts are exposed to antigens that then trigger an exaggerated cellular immune response and formation of granulomas. The pathologic feature of the diagnosis is the non-caseating granuloma. These granulomas are compact, centrally organized collections of macrophages and other inflammatory cells encircled by a ring of lymphocytes. With ongoing inflammation, the fibroblasts and collagen fibers begin to encase the ball-like cluster of cells. This creates a fibrotic shell, as seen here, and can produce the substantial and often irreversible organ destruction. Therefore, early detection and treatment is key to prevent this late-stage fibrotic response. There's often diagnostic uncertainty due to the clinical diversity and the resemblance to other more common disorders. In general, the diagnosis is established on the basis of compatible clinical findings supported by histologic evidence of non-caseating granulomas in 1 or more organs, and in the absence of other causes of granulomatous disease. Unfortunately, sarcoidal granulomas have no unique histologic features to differentiate them from other granulomas. Therefore, it's essential to rule out other alternative causes of granulomas. So once the granuloma is identified, it's important to rule out these other causes, including mycobacterial infection, fungal infections such as histoplasmosis and pneumocystis, hypersensitivity pneumonitis, beryllium disease, and certain medications such as methotrexate and some checkpoint inhibitors can actually cause granulomas. Discontinuing these medications typically leads to resolution. Without a definitive diagnostic imaging study, fluid analysis, or blood test, sarcoidosis remains a diagnosis of exclusion. Sarcoidosis is also a challenging diagnosis based on the number of different organs it can affect. Some of the most common organ systems include the lungs, skin, eyes, heart, liver, spleen, and parotid gland. Now I want to focus the rest of the talk on cardiac sarcoidosis, which is the second leading cause of death among affected patients following pulmonary sarcoid. Approximately 5% of those with extracardiac disease also have clinical manifestations of cardiac involvement. Although more recent imaging and autopsy studies have actually shown that cardiac involvement may be under-recognized and actually may be present in up to 1/4 of those with extracardiac disease. Patients with cardiac sarcoid most commonly present with AV block, ventricular dysrhythmias, and heart failure based on the geographic involvement of the disease. This diagram from the Burney et al. Manuscript in JACC from 2016 nicely demonstrates the variety of cardiac involvement that can occur and the ensuing problems. As you can see on the upper left corner, small patches of basal involvement is usually clinically silent. However, large areas in the septal area here can lead to heart block. The bottom left diagram here demonstrates reentrant circuits, which can occur as a result of fibrosis or granuloma, leading to VT or PVCs. And if the disease affects extensive areas of the LV and the RV, the patient may manifest as heart failure with or without heart block, with or without PVCs or VT. Something else to note, if you see a patient with non-ischemic cardiomyopathy, but with regional wall motion abnormalities, you may suspect cardiac sarcoidosis, since you usually don't get regionality with non-ischemic processes, whereas you can with sarcoid based on the patchy nature of the disease. Unfortunately, there's no currently accepted single set of guidelines for the diagnosis. However, there are 3 proposed sets of guidelines. The Japanese Ministry of Health and Welfare criteria, the World Association for Sarcoidosis and Other Granulomatous Disorders, and the Heart Rhythm Society. The World Association for Sarcoid and Other Granulomatous Disorders divide the diagnosis into highly probable, at least probable, possible, and no consensus. Highly probable corresponds to a greater than 90% likelihood and is based on endomyocardial biopsy. At least probable corresponds to 50 to 90% and is based off of certain imaging and clinical characteristics. Possible corresponds with less than 50% likelihood. I find the HRS criteria to be a bit more straightforward. It separates diagnosis based on histological diagnosis from actual myocardial tissue versus the clinical diagnosis. So like I mentioned, the histological diagnosis actually requires an endomyocardial biopsy, whereas the clinical diagnosis requires extra cardiac pathology, such as pathology from a lymph node or from an extracardiac source, plus certain clinical characteristics, including LGE on CMR, which was seen in our patient, uptake on cardiac PET, which was also seen in our patient, unexplained reduced LVEF, among several other clinical criteria. Endomyocardial biopsy has excellent specificity for diagnosis, but limited sensitivity given the patchy nature of the disease. Additionally, there are significant potential complications to biopsy, which limit its use in practice. Newer technology has been developed to increase the sensitivity, as can be seen here. It works by mapping out areas of possible sarcoid to direct biopsy, but there's not strong data to support its use. A safer option for diagnosis includes imaging techniques such as cardiac MR. There's no specific pattern of LGE or late gadolinium enhancement that is pathognomonic, and diagnosis cannot be made by CMR alone. Cardiac sarcoid typically includes patchy regions of LGE that spares the endocardial border and is not in the distribution of prior MI. The sensitivity and specificity of CMR for diagnosis were 76% and 92% compared with biopsy data, and 100% and 78% compared with the 2006 Japanese Ministry of Health and Welfare diagnostic criteria. It also has a negative predictive value, so it may be a reasonable first-line test in someone who cardiac sarcoid is on your differential. CMR is also prognostic. This single center study in patients with cardiac sarcoidosis demonstrated that in patients with LGE on CMR, had higher rates of combined adverse events and an increased hazard for cardiac death compared to those without LGE on CMR. The red line here is those with LGE on CMR, and the blue line here is those without LGE on CMR. One of the limitations of cardiac MR, however, is that it does not differentiate between active disease and not. FDG PET, on the other hand, does show you whether there is active disease based on uptake of radiotracer. FDG is a glucose analog, which is readily taken up by macrophages in areas of active inflammation. Fasting PET is useful for the detection of cardiac sarcoidosis, where the activated macrophages will take up FDG tracer. A systematic review and meta-analysis of 7 studies of FDG PET demonstrated a sensitivity of 89% and a specificity of 78% in the diagnosis. Additionally, FDG PET is helpful prognostically. In this study of 118 patients with suspected cardiac sarcoidosis, those with abnormal FDG and abnormal perfusion scans had increased rates of death and VT, as demonstrated by this red line here. This Kaplan-Meier curve with the blue line demonstrates either abnormal perfusion or FDG, and this green line shows normal perfusion and FDG. How do we treat cardiac sarcoid? Unfortunately, the optimal regimen is uncertain due to a lack of randomized data. Burney et al. In their JACC manuscript, published in 2016, propose a reasonable algorithm which suggests starting a prednisone dose at 0.5 mg per kg per day for 2 to 3 months, up to a maximum dose of 40 milligrams per day. Following this 2 to 3 month treatment, patients should have repeat PET imaging to evaluate for active disease. If active disease is detected following initial treatment, a second-line agent should be added. Reasonable second agents include methotrexate, leflunomide, azathioprine, and mycophenolate. However, if the FDG is negative for active disease, steroids should be tapered, and a repeat PET scan can be repeated after 3 months for screening. If disease relapse on this repeat PET, immunosuppression should be restarted. However, if there's no relapse, the patient can be monitored with ECGs and echoes. Another decision point regarding our patient's care is when to refer for ICD implantation. Different clinical manifestations of sarcoid lead to different recommendations for devices, some of which seem self-explanatory. Those with high degree AV block warrant pacer insertion. Those with heart failure with reduced EF, despite optimal medical therapy and immunosuppression, warrant ICD for primary prevention, such as our patient discussed earlier. Those with sustained VTs or VT arrest warrant an ICD for secondary prevention. In those with unexplained syncope or near syncope, which is felt to be from arrhythmia, an ICD can be considered in these patients. And in someone with an EF greater than 35%, recommendations become less clear. ACC guidelines suggest considering a CMR or an EP study for further risk stratification. The prognosis of these patients is excellent, with transplant-free cardiac survival in the 90% range at the 1 and 5 year mark and 83% at 10 years. That data comes from a cohort from Finland. In the United States, those with cardiac sarcoid have a 5 and 10 year survival of 95.5 and 93.4% respectively. In those who do require transplant, the post-transplant outcomes are similar to those who require transplant for other types of cardiomyopathies. Patients in general are immunosuppressed to a greater extent to prevent recurrence of cardiac sarcoid, which remains a risk. Patients with cardiac sarcoid have similar post-transplant hemodynamics as demonstrated by this study here, which looked at right heart cath numbers in those transplanted with cardiac sarcoid versus those transplanted with other types of cardiomyopathy. To summarize, the exact cause of sarcoidosis is unknown and is likely the result of genetically predisposed individuals who are exposed to certain environmental and/or microbial triggers. Cardiac sarcoid is a very challenging disease to identify, in large part due to its heterogeneity in clinical presentation. The absence of a diagnostic reference standard for sarcoid and the difficulty associated with endomyocardial biopsy makes the diagnosis very challenging. CMR and FDG PET have reasonably high sensitivity and specificity, which can aid in diagnosis along with extracardiac histology. Steroids and steroid-sparing immunosuppressives are used for management, and prognosis in identified patients is good, with a 10-year free survival in the US of 93.4%. Future research efforts should focus on improving the accuracy of diagnosis and the standardization of diagnostic algorithms. Future research should also look at evaluating optimal treatment strategies, preferably steroid-sparing therapies, and understanding more clearly the appropriate timing for referral for ICD. Cardiologists, rheumatologists, pulmonologists, and other specialists will need to collaborate to identify appropriate time for referral for our patients to improve our understanding of this complex multi-system disease. I wanted to thank Dr. Bott for his mentorship throughout making this presentation, to Dr. Vadnais for reviewing the cardiac MRI images with me, Dr. Moncayo for reviewing the PET images, and Dr. Westerman for reviewing the ICD data.
Thank you, Arielle. Good, excellent review. A very interesting, always interesting topic. This case, I guess it's interesting a little bit for he's sort of, other than the PVC's lack of arrhythmias, which is usually such a hallmark of these cases, and just more of sort of a classic heart failure presentation. Maybe I missed it, and I know it's not a terribly sensitive or specific test, but ACE level, do we check an ACE level on this gentleman, and was it at all useful in his evaluation?
Yeah, that's a good question. I actually looked for that in the EMR, but did not find an ACE level that was sent. It's often one of those things that's done. In this case, I'm not sure. I mean, this was pretty, obviously there wasn't by the end much in the way of a diagnostic dilemma anymore. I think it was pretty clear after some imaging what this gentleman had. But I mean, I do think it's something we generally do. I'm not sure how often it actually helps in these cases, but yeah. In reviewing the literature, it actually didn't come up all too much. So I'm not quite sure how often that's done or how sensitive or specific it is.
I think it's present in less than 20% of the patients, but we check it all the time.
Other questions from the audience?
Arielle, this is Kunal. That was fantastic. I've heard a lot of sarcoid talks through the years, and I thought you did an excellent job. So I know I told you I was going to ask you this question, Arielle. So if you see a patient like this in the future, what is going to be your algorithmic way of evaluating this? How should we promote all of our colleagues and fellows in working up somebody with sarcoid? What would be your method going forward?
So in reviewing the literature, it seems that cardiac MR has a very high negative predictive value. So if evidence of cardiac sarcoid or evidence of patchy cardiomyopathy is not seen on CMR, then I think we can feel good that either the patient likely does not have the disease, or we can be reassured that the event-free survival is pretty good. So I would probably start with a cardiac MR. If there is continued suspicion for the disease, I do think that this patient will need an FDG PET as well. The benefit of the FDG PET is that it can actually show active disease, and it can also show whether or not there's extra cardiac disease, which may be more amenable to biopsy. So I actually think that you need both if suspicion is high enough.
Yeah, and I think one thing that's important to make note of is, when we get patients with heart block, oftentimes they get rushed to getting devices. Sometimes it's nice to get a baseline cardiac MR on those patients before a device goes in. It's not because you cannot get an MR on patients with ICDs and pacemakers, but the diagnostic yield drops because of the device itself. And then second is, when you get a cardiac PET, when you're trying to make an initial diagnosis of cardiac sarcoid, it's very important to get a whole body PET. And so oftentimes in cardiology, we order specifically a cardiac PET looking for sarcoid. But if this is a new diagnosis and you're going to need pathology from extra cardiac tissue, it's important to get that whole body so that we can chase after the liver or the spleen or the lymph nodes to really clinch the diagnosis, because going after the heart in a biopsy, as you've shown, is very low yield. So when you're going for an initial diagnosis, the whole body PET is actually very important in addition to the cardiac PET. And oftentimes when I see patients that have been newly diagnosed or suspected for this disease, I oftentimes have to go back and do a whole body PET because all that's positive is a small area on, the left ventricle, which
Right.
is going to be near impossible to chase after from pathology standpoint.
Right. Thank you.
Hi, Arielle. Great talk. I also had a quick question. I was wondering if you knew how much more mortality benefit do these patients that end up getting like a pacemaker or ICD placed for having arrhythmia issues. Just wondering because at least like in amyloidosis, I've been always told that there's not much mortality benefit for those type of patients with infiltrative disease. So I was wondering if sarcoid is similar.
Yeah, that's a good question. I did not come across any literature that aimed to answer that question. I don't know if Dr. Bott has more information.
I can't give you a specific number, but being a pro-arrhythmic disease, sarcoid, I think it's not refuted that ICDs are beneficial.
Hey, Arielle, this is Raja Laskar. Great talk. Quick question. I think the issue beyond diagnosis is that I have clinically is the utility of repeat PET scanning when you've made the diagnosis, particularly if there's extra, cardiac manifestations or extra cardiac manifestations. And it seems like how much more useful is that? I know Dr. Bott and I have discussed this before, but how much more useful is that versus following things clinically? In other words, obviously you're giving high dose immunosuppression, high dose prednisone, and you want to get them off that. Are we really going to make immunosuppression choices based on the PET scan versus extra cardiac manifestations or LV functions getting better? I don't know if you have any thoughts on that.
Yeah, I think that's a great question. The algorithm from the Jack manuscript that I showed, they suggest repeating PET scans throughout the treatment algorithm. I think that the most satisfying scenario would be you see a patient with active FDG uptake on a PET scan, you treat them, they clinically get better, and their repeat PET scan now does not have any FDG uptake. I think that would be like the ideal scenario. What happened with this patient is he did have a repeat PET, And unfortunately, it was inconclusive. And it's my understanding that a lot of these FDG PET scans have problems, because if the patient maybe ate some sugar, you're supposed to go on this low carbohydrate, high fat diet for 2 meals before and then do a prolonged fast. The idea being you suppress myocardial glucose uptake so that the FDG is only taken up by active inflammation. However, if the patient doesn't fully, comply with the diet, then there can be some problems with the test, and the test can be inconclusive. So I don't know, Dr. Bott, if you have any more thoughts on how often you are ordering PET scans versus just kind of relying on clinical improvement.
I think, Dr. Laskar, your question's a very, very good one, and it comes up all the time. I think more so than, for me, the PET scan helps wean off immunosuppression more than it does, help in continuing immunosuppression or adding more immunosuppression. So i.e., if somebody's doing fantastic and, they've been on prednisone now for a year, it may help you try to consider weaning them off prednisone or lowering their immunosuppression overall. It may not help you if the PET scan is still positive, but the guy's like in the gym, working out harder than you are. I think in those cases, you defer to the clinical part and say, we're not going to change treatment. At least that's how I've done it. I know the algorithms always say if there's continued FDG uptake, you should consider second and third line therapy. It's really hard to do that, knowing that there are so many faults in the imaging. So I think for me, it's more so to help wean off immunosuppression rather than add more on, if that makes sense. If the clinical situation is diverging from the imaging.
Robbie?
Yes, sir.
So that was a good presentation. Thank you, Kunal, for your remarks. I've often thought about sarcoid and the MRI and echo images, and I would say that it seems to me that we don't think of sarcoid enough early on, although that's changing. For example, the patient that comes in with VTAC, this unexplained sarcoid comes into it. The patient with an MRI that has the unusual subepicardial, not subendocardial scar or edema in the early phases of sarcoid of the heart rather than end-stage sarcoid. It's one thing to be in the clinic and the dermatologist refer you a patient or the pulmonologist refer you a patient, said this patient has sarcoid in the lymph nodes. Do they have sarcoid of the heart? Then we start going through our little song and dance, making a diagnosis. But it doesn't seem to me that we as cardiologists do our job in thinking about sarcoid enough when we see patients that have advanced heart failure or is this end-stage sarcoid or earlier, and we don't have the opportunity, such a rare disease. So I think that our thinking about sarcoid and putting on that list of the differential and the availability of MRI has kind of discovered more of this as time has gone by. So when we see a patient that has some acute syndrome or a patient that has VTAC, we need to put sarcoid on the list more often, especially in the Southeast. So that's kind of my overall comment. It's diagnosed on MRI, I would say a lot. Kunal, what would you say about how do patients who you see, what is the diagnostic clue that comes up that allows you to say it might be sarcoid?
I think you sort of hit it, Rod. if you have somebody who's young, who has a non-ischemic cardiomyopathy, has wall motions that don't seem to make sense, I think that's one clue. Second is, I think more and more folks are ordering cardiac MRIs in patients with non-ischemic cardiomyopathies as a way of just making sure that they've thought through all the other infiltrative etiologies, and we're picking up more sarcoid that way, agreeing with what you're saying with the
So
MRI.
let me ask you another question. So when you read all your echoes and you read hundreds of echoes, how often do you like put a sentence at the end, say this pattern in the ventricle is a little unusual, you might consider sarcoid? How often do you write that on the report? And Robbie, that question is for you.
Yeah, not as often as you do.
Yeah,
Well,
exactly.
Well, I guess my point is it's not very often, but it probably should be more often. But you got to put that in your thinking algorithm. Okay,
Agreed.
thanks.
Agreed.
And there's these apocryphal tales. Kunal can probably, or Raja can back us up. These patients you send for LVAD, and they send the cord out piece of the apex for histology, and they end up seeing non-caseating granulomas in a patient just thought to be a run-of-the-mill non-ischemic cardiomyopathy. I don't think that happens terribly often, but it probably happens every now and then. And it's like, oh, this patient actually had cardiac sarcoid after all.
Yeah, agreed. The other thing I've seen that's also like very strange, but like patients who are young, 50, 60, had heart block, got pacemakers, and then a year later they arrest at home or arrest at work, and then get brought back. And then sure enough, now in retrospect, it's like, oh, it's sarcoid the whole time. But, folks who have conduction system diseases without clear reasons why, I think those patients we need to be
or
highly suspicious.
non-ischemic folks with aggressive ventricular arrhythmia stuff. So obviously that's someone that can.
Yep.
All right. Dr. Laskar, you unmuted.
Oh, this is another quick question for Dr. Schwartz and Dr. Bott. I guess the other manifestation that I have a question about is those patients who've had sarcoid for a long time and have gotten scar, and is that another indication to kind of back off on immunosuppression if possible? So there's certainly people who have extra cardiac manifestations where it's quiet and they've had it for years. I guess my question is, are we over immunosuppressing those patients as well? And is that the best way is, as you said, is a cardiac PET versus, seeing what the MRI looks like?
So your question is if there is evidence of scar on cardiac MR, but no evidence of inflammation on FDG PET?
Yeah, because we've spent a lot of time in this talk about diagnosis, but there are obviously patients who've had cardiac sarcoid for years, decades even. And I think some of those patients, they're not going to get any more inflammation, and they may need a little bit of background immunosuppression, but they really have more scar. And in those patients, we really should be, I guess my point is, I think we really should be backing off IS in those patients.
I see.
Yeah, I agree, Dr. Laskar. I think if you've had like VT arrest at home, if you've had high degree AV block, and now have end stage heart failure, probably 5 milligrams of prednisone is the most that we ought to advocate for. When they come into the hospital with heart failure, and blasting them with Solu-Medrol and all this stuff becomes really difficult to prove unless you've got clear evidence of inflammation. And so, once the process is end stage, I agree, we should probably start backing off because we cause more harm than good. And we've certainly had cases like that recently where people get over immunosuppressed and unfortunately succumb to opportunistic infections prior to transplant or after VAD. So.
Okay, well, thanks again to Dr. Schwartz for an excellent presentation, and thanks for everybody for tuning in. Everybody have a fantastic Thanksgiving, and we'll see you in 2 weeks.
The preceding program is copyrighted by Emory University.